So as we continue our look to the future, as Ron Kahn so elegantly stated, I'm pleased to announce our last, but certainly not our least speaker of this symposium, Dr. Lorraine Lipscombe. Lorraine is a clinician scientist at Women's College Hospital and professor at the University of Toronto. She's a world leader in the translation of knowledge to understand the who, what, why, where, and whens of the current diabetes epidemic in studies that range from the individual patient to entire populations. In recognition of her leadership and innovation in studies of diabetes epidemiology and health services, Lorraine was recently appointed as the inaugural director for the University of Toronto's Novo Nordisk Network for Healthy Populations, which is a cross-disciplinary research network based at the University of Toronto Mississauga campus. So without further ado, I asked Lorraine Lipscombe to come up to the podium and present her lecture entitled Insulin and Beyond, Addressing the Challenges of Diabetes in the 21st Century.
Thank you very much, Dr. Brubaker, for that introduction, and thank you for giving me the opportunity to present to you today. And it gives me great pleasure to follow those distinguished speakers who gave you such a great journey in the discovery of insulin and other important advances. And I'm going to now move to addressing the challenges that we have around diabetes in the 21st century. I'm going to talk first about challenges and priorities specific to type 1 diabetes. Then I'm going to follow to talk about what we need to do to address the epidemic of type 2 diabetes. And then I'm going to end by briefly touching on some solutions and future directions, highlighting some of the work that we're doing at University of Toronto. So we just heard how the discovery of insulin has transformed the lives for countless people living with type 1 diabetes. And since that time, we've seen huge advances in type 1 diabetes management and how we treat and deliver insulin. We've gone from delivering insulin through painful glass syringes to plastic syringes to pens, then following the first insulin, very cumbersome insulin pump prototype you see there, all the way to the more discreet ones that we have today. And now with the advent of really effective glucose sensing technology, we actually have pumps that can respond to real-time glucose sensor data and auto-adjust basal insulin throughout the day. And these innovations have greatly improved the ability for patients with type 1 diabetes to achieve glycemic targets safely with a reduced risk and more conveniently with a reduced risk of hypoglycemia. And all of these advances have led to vast improvements in the life expectancy and well-being of persons living with type 1 diabetes. And these are data that you can see here from 6 countries that are able to track persons with type 1 diabetes. And you can see that even since 2000, the mortality for type 1 diabetes declined significantly in all 3 countries up until 2020. You can also see on the graph on the right that when we compare mortality rates to the general population or the standardized mortality ratio, this ratio dropped for 3 of the countries and stayed the same for the other 3. And while this is really good news for people with type 1 diabetes, you'll still note that the mortality for diabetes is still over 2.5 times higher in 2020 for people with type 1 diabetes. So we need to do better. So what are some of those unmet needs and research priorities for type 1 diabetes in the 21st century? So first of all, we need to pay more attention to those psychosocial and access barriers to effective diabetes management. We recognize that many patients are still not able to achieve optimal diabetes control. And we need to recognize that type 1 diabetes affects every aspect of a person's day-to-day life and is often overwhelming for patients, making it difficult for them to manage their condition effectively. This is a quote from a patient with type 1 diabetes. It's a terminal disease. We work our butts off 24 hours a day, 7 days a week, no breaks, no vacations, or else we die. We fight for our health every minute of every day. And so it's no surprise that 50% of individuals with type 1 diabetes experience so-called diabetes burnout at some point in their lives. And so researchers will really need to identify ways to reduce this burden. But there is hope. Researchers are continuing to test newer technologies, adjunctive to insulin therapies, and we're starting to see promise for treatments that can actually preserve or replace insulin production. And so these advances will hopefully continue to improve outcomes for persons with type 1 diabetes and relieve that burden of managing the condition. And, but of course, as these new innovations become more available, we need to ensure that barriers to access are minimized. And our very own clinician scientist, Alana Weissman, is doing just that. Her Equate T1D study is going to evaluate barriers to diabetes technology use, specifically in marginalized communities, which will then inform an intervention to break down those barriers. Now, our own Bruce Perkins is leading the way to identify blood glucose management systems that will be more accurate, easier to use, and move closer to fully automated insulin delivery, or a so-called artificial pancreas. And I thank Bruce for sharing this beautiful slide with me. And he and his colleagues are also working to evaluate the potential effects of add-on therapies such as SGLT2 inhibitors, and with a recent publication in Nature Medicine showing the benefits of empagliflozin in patients with type 1 diabetes. Data on treatments that can preserve insulin production in newly diagnosed patients are also emerging. This paper, published just last month in the New England Journal of Medicine, looked at the benefits of the effects of teplizumab, which is an immune modulator, on beta cell function in children and adolescents with newly diagnosed type 1 diabetes. And they were able to show that a significant increase in C-peptide levels, the endogenous breakdown product of insulin, and a reduction in insulin dose. But what's really exciting is the promise of insulin dependence. While the advent of islet cell transplantation last century was revolutionary, this treatment has always been limited by the availability of viable islet cells. And so this study of VX-880, which is a novel stem cell derived islet cell therapy, was presented at ADA in June, where they gave 6 patients with type 1 diabetes VX-880, and all of them showed improvements in glycemic control with decreased insulin need. And after 24 months, 2 of the 6 patients were actually able to achieve insulin independence. But as we continue to make these great advances in type 1 diabetes, unfortunately, the world is currently being overwhelmed by an epidemic of type 2 diabetes. Now, the 20th century also saw major advancements in management strategies and therapies for type 2 diabetes. We just heard about the amazing advances related to the discovery of GLP-1 and the advent of GLP-1 receptor agonists, in addition to SGLT2 inhibitors. And in fact, this has had, the good news is that these advances, even with respect to earlier changes in treatment and multifactorial management of type 2 diabetes, have led to significant reductions in diabetic complications and cardiovascular risk. And here are results of an Ontario study that we conducted, led by another clinician scientist at the University of Toronto, Calvin Key, where you can see, looking at Ontario data, that the event rates for cardiovascular disease have significantly declined in this century up to 2014 for patients with diabetes, such that now diabetes is no longer a cardiovascular risk equivalent. And so this is, again, really good news. And we heard about all the upcoming further advances in treatment of type 2 diabetes from previous speakers. However, with the continued rise of cases of type 2 diabetes, our health systems are going to become increasingly overwhelmed. It's going to become increasingly challenging to be able to provide this type of effective care to everybody who needs it. And we're soon going to lose some of these gains that we have made. Now, the increasing availability of population-based databases over the last 3 decades have allowed us to track the epidemiology of diabetes, and the news is not good. And this was one of the first population-based studies from Ontario that we published using healthcare databases. And we were able to show, whoops, sorry about that. We were able to show not only did the prevalence of diabetes go up by almost 70% in only 10 years in Ontario, but that prevalence in 2005 had already surpassed the global prevalence that the WHO had only projected was going to occur in 2030. And this epidemic is continuing to increase, has continued to increase since then. This is a figure from Diabetes Canada showing the ongoing increase in the proportion of Canadians who are living with either diagnosed or undiagnosed diabetes or pre-diabetes from 2005 to 2020 with projections up to 2025. And you can see that the proportion affected is now 1 in 3, with 13.6 million Canadians estimated to be affected in less than 2 years, with huge economic impact. This epidemic is also being experienced throughout the world, with an estimated further increase of 46% by 2045 if we don't do anything, as you can see in the upper slide there. But the most troubling statistics are those seen in low and middle income countries. As you can see, I'll just say, as you can see here in the lower figures, the biggest increases are expected for South and Central America, Africa, the Middle East, and Southeast Asia, ranging from 50% to 134% by 2045 in Africa. So we are just seeing the tip of the iceberg of the diabetes epidemic, particularly for developing nations. Now, this paper that was recently published in The Lancet was able to estimate global projections of diabetes prevalence to 2050, and we're able to tease out the increase of type 1 versus type 2 diabetes. And as you can see, that the epidemic is being driven by a rise in type 2 diabetes, with almost 10% of the world population being affected by type 2 diabetes in 2050, or an estimated 1.3 billion people. And they were able to look at the contribution of different risk factors to this type 2 diabetes epidemic, and high BMI accounted for 52% of the risk. And so our efforts will need to address the concomitant global rise in overweight and obesity that's driving this epidemic. And indeed, the world regions have also seen a massive increase in obesity prevalence, reaching 14% overall and over 20% for the Americas by 2020. And lest you think Canada is doing better than the rest of the Americas, in 2018, 1 in 4 adult Canadians are now living with obesity, with a prevalence about 27.2. And these maps here illustrate the rapid increase in the proportion of Canadians that had been affected just since 2005. And we now only have 4 provinces with obesity prevalence less than 30%. So unfortunately, the only way that we're going to be able to address this is by thinking about how we can prevent the ongoing rise of diabetes and obesity. And to do that, we have to first understand what are the drivers of this epidemic. What are the root causes that are leading to this relentless increase in obesity and diabetes? So over the last 30 years, we can all agree that the world has seen massive shifts in our environments and in the way we live our lives. We have to remember that humans are hardwired to conserve energy, and we have successfully engineered obesogenic societies that are the envy of our ancestors. Ready access to cheap, high-calorie, shelf-stable foods, and the ability to work, travel, learn, play, and socialize with minimal physical movement. We now are effectively able to maximize energy consumption and storage and minimize energy expenditure. And so we have to start with this recognition and work from there. We also know that diabetes does not affect everybody equally. the burden of diabetes is substantially higher in Indigenous communities, visible minorities, and those of low socioeconomic status. And these are findings, early findings from one of our clinician scientists, Beju Shah, where he compared diabetes prevalence by ethnic groups in Canada and compared to people who self-report white ethnicity. He showed that prevalence rates of diabetes are 2 to 3 times higher in South Asian and Black populations. Similarly, U of T scientist Ghazal Fazli looked at ethnic differences in pre-diabetes incidence among new immigrants to Canada. And you can see that by 12 years after immigration, the biggest rise in new onset of pre-diabetes was among South Asians at about 23%. And so Beju, Ghazal, and others are now studying ways to address this unequal burden of diabetes amongst these populations and provide more customized prevention and management strategies, these populations being highly represented in Canada. Now, these strategies will also need to address the underlying factors that are driving these inequities in diabetes risk, the so-called social determinants of health and living environments. And so this figure by the Canadian Medical Association has broken down sort of the different factors that lead to illness, chronic illness in Canadians. And you can see that they estimate that about 50% is contributed to by so-called social determinants of health or your life, things such as income, disability, education, housing, et cetera, with another 25% due to healthcare access, 15% due to biology, and 10% due to the environment. And this is especially true for type 2 diabetes and obesity, which are tightly linked to barriers to health behaviors. This figure illustrates the different socio-demographic conditions at the individual, household, community, and national level that can influence risk of diabetes and obesity. And these influences not only affect a person's ability to make healthy choices, but can also have long-lasting and cumulative effects starting early in life, even before birth, through the developmental changes in the womb in response to adverse nutritional conditions. And this partly explains the unequal risk of diabetes and cardiovascular disease we see among people from developing nations, especially when they then transition to more nutritionally rich environments. Now, where we live can also have a substantial impact on our ability to make healthy behavior choices. And the world has also seen a big change in our built environments that make it more difficult for us to be physically active and to access healthy foods. And research has shown that several features of this environment can affect our abilities to make choices and can affect the risk of obesity and diabetes. Things such as the walkability of our neighborhoods, access to parks and natural environments, access to ability to undergo active transit, such as walking and cycling, our food environment, housing, and air quality. Now, Dr. Gillian Booth at University of Toronto has been leading the way in this area. And this is a paper that she published a few years ago showing that compared to individuals in Toronto who live in the most walkable neighborhoods, people in the least walkable neighborhoods at a significantly higher likelihood of developing new onset diabetes 10 years later. Now, I'm going to move on to briefly discuss the work we have ahead of us to address these issues and some future opportunities for research. Now, in 2021, the WHO put out a call to action to address the global diabetes epidemic with 4 priorities. First, to strengthen capacity, leadership, governance, and multi-sectoral action for prevention and control. Second, to create health systems with more integrated, person-centered, community-based, and sustainable diabetes care to be able to meet the demands of the increasing number of people who are going to require effective care. Third, to reduce modifiable diabetes risk factors, go upstream and try to reduce the risk of getting diabetes in the first place through changes in our environment and social conditions. And finally, high quality data collection and research to make sure we can track what's working and what isn't. Similarly, in 2022, the federal government of Canada passed a bill for a national diabetes framework to reduce the impact of diabetes in Canada, which is intended to unite provinces around policies for diabetes care and prevention, with a particular focus on reducing health inequities and improving access to health services. But responding to these calls to action are going to require new and innovative solutions. We're going to need to move out of our own labs to work with other disciplines, and we're also going to need to move beyond our universities to work with key stakeholders and knowledge users to be able to make effective change. And I'm going to highlight two novel ways that researchers at University of Toronto are responding to these call to action. Number one, by leveraging big data and AI, and secondly, through using strategies such as implementation science to translate evidence into practice. Now, the turn of the 21st century, as you know, has continued to see an explosion of large sources of different types of data, big in terms of volume, velocity, and variety. There's now capacity to link health and medication information that we've had for a while now with multi-omic databases, as well as structured and unstructured data from smartphones on social and behavioral trends, social media, and environmental data. However, it wasn't until the advent of machine learning and artificial intelligence, or AI, innovations that we now have the opportunities to integrate these complex and unstructured data sources to actually ascribe meaning to the data from them and answer important questions to support things like early risk prediction, differential diagnosis, and treatment optimization. And U of T scientist Laura Rosella is leading research using AI to create population prediction models for diabetes, both for diabetes complications and to predict diabetes onset. And these learning models can be applied to understanding the distribution of risk in the population, diabetes management and prevention, health resource planning, and decision-making. But one of the challenges has been how to deploy these models in clinical care that is ethical, useful, and acceptable for patients, providers, and policymakers. And to that end, we recently received funding from CFAR to establish a cross-disciplinary network co-led by Dr. Laura Rosella and Jay Shaw to develop and ethically deploy type 2 diabetes prediction models within primary care. This network will work with local stakeholders in the region of Peel to understand how best to do this. And this is, so Dr. Rosella and her colleagues are also using AI to test the potential impact of preventative strategies on future diabetes rates and costs. And this is an example of an AI-driven modeling study that combined survey data with healthcare data to understand the projected impact of different diabetes prevention strategies. So the first model looked at the impact of a lifestyle program that would be implemented to individuals who are at high risk, which would be about 10% of the population, but would result in a 7% reduction of weight, which is what we saw in the evidence-based diabetes prevention program. And indeed, she showed that this would result in a significant reduction in future diabetes cases, as well as healthcare savings. But she then went on to look at what would happen if we then instead implemented a combination of population-wide policies that only resulted in a 2.5% reduction in weight, but for the whole population. And as you can see, this approach actually would stand to reduce more future diabetes cases and save us over $100,000, over $100 million more dollars in healthcare savings. So this suggests that in addition to using both targeted and population-wide approaches to prevent diabetes, greater efforts should likely be directed towards population-wide approaches. And so now I'm just going to briefly move on to how can we translate evidence into action. You know, we all know that we have ample evidence for effective treatment and preventative strategies for diabetes, but this evidence has insufficiently been translated into practice. And so like Banting and colleagues and McLeod and colleagues illustrated 102 years ago, research will need to shift from testing what we think might work to showing what does work. And while our colleagues working in discovery science are translating evidence from bench to bedside, we need to translate evidence from trials and databases to communities and systems. So to meet this challenge, researchers are now turning to the principles of implementation science to effectively bridge evidence and practice. And this includes partnering with knowledge users at the outset to co-design implementation strategies that inform adaptations of interventions that we know are effective, but changing them for local contexts and needs, and ensure that iterative evaluation and improvement is continued to make sure that intended outcomes are being achieved in the real world. And to help foster this research, CIHR has recently invested in funding millions of dollars in implementation science projects and team grants to help translate evidence-based healthcare interventions into Canadian settings. And one example is what we're doing to bridge the gap for diabetes prevention for women who've had gestational diabetes. We designed and trialed a diabetes prevention program for postpartum women who've had gestational diabetes, but the biggest challenge has been then to create a care transition pathway to refer women for postpartum care and then implement the program. And so we recently received a CIHR grant to be able to do this work in 3 Ontario jurisdictions. And several other scientists at the University of Toronto are also doing implementation science work to to translate evidence around better models of care for diabetes into practice. Now, finally, I'm just going to have a word about the Novo Nordisk Network for Healthy Populations. So with the establishment of this network in 2021, we now have the opportunity to translate evidence into practice on a much wider scale. Thanks to a donation from Novo Nordisk Canada to the University of Toronto to mark the 100th anniversary of the discovery of insulin, the Network for Healthy Populations will build capacity across 3 University of Toronto divisions for cross-disciplinary research to address the burden of diabetes. With its base at University of Toronto, Mississauga, we will be focusing on the region of Peel, who have some of the highest rates of diabetes in the country, as a local context to co-design, implement, and evaluate innovative solutions that can then be scaled to other settings. And so tackling the diabetes epidemic, I hope I've convinced you, is going to be a tall order. It's going to require a comprehensive approach that integrates clinical, community-based, and population-based strategies. So to that end, the network is focusing on 3 streams of work. First, at the micro level, to improve the care of patients living with diabetes and chronic disease in the healthcare system. Then we're going to move beyond the healthcare system to also target at the meso level communities to reduce risk factors for diabetes, particularly in high-risk populations. And then at the same time, moving towards the macro level to look at policies, to implementing population-wide policies to create healthier environments. And we are just getting started, so please stay tuned. So I'm going to end there just to summarize that we have a number of challenges ahead of us. For type 1 diabetes, we need to address ongoing barriers to effective care, but there are great new innovations on the horizon that are showing promise. For type 2 diabetes, the world is facing an epidemic of type 2 diabetes and obesity, so we need prevention is really going to be the only solution. We need to address social and environmental root causes. Big data and AI provide new opportunities for policy-relevant research, but we need better strategies to move evidence into practice if we want to see sustainable change. And I will thank you for your attention.